Tonight we're going to talk about pre and post surgical BFR and so there's some ideas around how to utilize it, how to prevent some muscle atrophy and the long rehab process that goes along with it. What we're going to talk tonight about is really about using ACL for surgeries pre and post. I'm going to use ACL as my primary example tonight, but I use it for all different types of surgeries. Right now I have an ACL, I've got a bicipital repair, post-surgical low back, meniscectomy. I mean, I just use it for pretty much anything that we can't use heavy loads with. So I always prefer to use heavy loads, but if I can't use heavy loads, I'll use BFR instead. Just quickly about me, I'm Director of Education for Smart Tools. I've been so for about 10 years. I've done other work with Rock Tape, TRX, Trigger Point Performance, Fizmodo, lots of different companies. I own my own clinic in Dallas, Texas called Body Lounge Park Cities, where we do functional medicine. We do hormones, peptides, aesthetics. We kind of have a full-on party up there every day. I'm finishing a nurse practitioner degree, so I'll have that finished next year. My PhD is in sports medicine, athletic training. So I love BFR because for so long I was trained that you had to lift heavy loads in order to get muscle strength and hypertrophy. Like according to the ACSM, you know, they talk about 70% of your 1 rep max, but what we knew in rehab was that using TheraBands and light loads and body weight probably wasn't enough. And when we discovered BFR, I was able to use those light loads, same exercises that I used in the past, that I was able to add the cuffs, and then all of a sudden I'm able to get muscle strength and hypertrophy in a pretty short amount of time, like 3-4 weeks. So it really changed the way that I do rehab. And so now I like to share it and show others how to utilize it. So tonight we're going to just kind of talk about these orthopedic injuries. I use ACL. I've torn my ACL 3 times. I was a Division I wrestler, tore it one time wrestling in college, had it repaired, tore it again, had it repaired, and then I did it the 3rd time, wakeboarding, and I just decided not to have the surgery again. So I go without an ACL, but I'm not, you know, I'm 52, so I'm not doing anything too crazy. But I ski, and I can't run 2 days back in a row without some significant swelling. I can't squat, 2 days in a row without some significant swelling and some pain. But for the most part, I get along pretty good, do everything that I want to do. So that's why I kind of use the ACL, and also because we just see so many of them. And also, it's one of those that we can catch early. You know, most of the time, like with my ACLs, you know, it was never like I tore my ACL today and I had surgery tomorrow. It was like I tore my ACL, waited 3 or 4 weeks for MRI because we needed the swelling to go down, and then I scheduled the surgery afterwards. So we have time before these surgeries to do some pre-surgical work, which I think goes a long way in the rehab process and reducing the whole overall return to play timeline. One of the things I think most people don't really understand is how quickly atrophy kicks in. So atrophy is the muscle wasting, and that muscle wasting can occur super, super quick. After a traumatic injury, it can occur within 24 to 48 hours. And we get significant reduction by day 10, both in strength and size. So in my opinion, we need to get after these exercises as soon as possible. And then when it comes to like the surgeries themselves, something called a reactive oxygen species occurs, an overreaction of the reactive oxygen species phenomenon after the surgical tourniquet is removed and the blood is flushing back into the limb. And that can cause a lot of damage. If anybody's seen an ACL pre-surgical and then immediately post-surgical, it's crazy how quickly that leg atrophies and becomes so weak. So we know that there's a surgical component as well. And I can argue that using BFR prior to surgery not only helps with size and strength maintenance, but also prepares the limb for that surgical tourniquet and reduces the damage done by the reactive oxygen species and the perfusion reperfusion phenomena. Now here's just some pictures of some patients, pre and then post. Nice little patellar tendon graft. And as we all know, there's, a ton of ACL tears every year. I think in the NFL, I'd have to look. I should have looked before this, but I think they're at 50 or pretty close to 50 so far this year. I know my team, the 49ers, we've suffered two to a couple of our defensive linemen. That is really not making me happy. But, they're happening all the time. We see this quadricep atrophy occur quick. We get this calf atrophy that occurs quickly. And then, of course, everybody that's in the rehab world knows, the chances of tearing your opposite side limb is very high. And then re-tearing the same limb is very high, like what happened with myself. This is what I mentioned before, that within 3 days, we start to see protein markers of type 2 fibers break down. Those start to increase. And so just within 3 days of disuse, at 10 days of disuse, we can have up to 50% loss in fiber area. We can lose strength by about 30%. And protein synthesis can drop significantly. And we'll talk a little bit more about muscle protein synthesis and the importance of keeping a positive balance in order for strength and hypertrophy. But we have to remember when we're rehabbing folks how quickly this kicks in. And so it's always been my opinion to start exercises as soon as possible. Even with my acute low backs, I start exercise. Might not be resistance exercise, but it's something on day one, because I want to get that ingrained into my patients that they're going to have an active component in this, and they're going to get going right away. So like I mentioned, atrophy starts immediately. I thought this was a very interesting study by Candill in 2023. The top two slides, or the top pictures, are post-op and pre-op of the reconstructed limb. And if you look at the quad size on the bottom two, C and D, this is the non-reconstructed limb, meaning that not only is disuse affecting the affected limb, but it's really affecting even the rest of our body. And so even if I have an injury with somebody, let's say a bicipital tear, it's going to get repaired, I really encourage and try to emphasize patients getting in on working the rest of their body, even if they're if they tore their right arm, using their left arm in order to get a crossover effect and reduce atrophy that occurs in the non-involved arm. Same thing with legs. Same thing with the cardiovascular system. We start to lose cardiovascular aerobic capacity at about 7 days. So it happens really, really quick. And so we want to just maintain our gains and get people moving ASAP. So we're looking at a net protein balance. So whenever we're looking at either building muscle mass or losing muscle mass, it's all about this net protein balance. So muscle protein synthesis, how much the muscle fibers are growing versus how much they're breaking down. And we want to always maintain a positive protein balance. If protein balance is negative, then we're gonna lose mass. And the way that we stimulate protein synthesis is through resistance training, mechanical tension, and also protein availability. So making sure our patients, or if it's us ourselves that are rehabbing, are keeping high protein diets to make sure that we're getting the adequate nutrients we need. Other things I'll do for people that are vegetarian or vegans, I'll use, and they're not going to be eating animal proteins, is using just straight amino acids to make sure that they're getting the protein that they need. You can also use, non animal-based, like pea protein, rice protein. A lot of those are missing certain amino acids like leucine. So you just got to make sure that they are a perfect protein and that they're getting all the essential amino acids. So loading up on protein, doing resistance training, and trying to maintain that muscle mass as much as possible. We talk about two different types of atrophy. We have a disuse atrophy. That's our kind of our slug atrophy, like just not using the limb. That could be not our fault. It could be, you know, I've got a cast on, I've got a brace that's locked, I can't use that limb. But mostly that's going to be done from inactivity. And then we got traumatic atrophy. And this is a faster, deeper, more resistant type atrophy. We get kind of a neurological shutdown plus cellular damage that contributes to this type of atrophy. I like to talk about the iceberg of atrophy, where we can only see about 10%, which is we see the loss in muscle mass, but there's a lot of other hidden factors that are included in atrophy. Things like neural inhibition, altered mechanics, pro-inflammatory cytokines, fiber type transition from type 2s to type 1s, increased catabolic pathway activation, reduced satellite cells. All these things contribute, and a lot of it is at our metabolic level, not at what we can see level. I believe that we become more insulin resistant in that muscle fiber as well when it's not being used. So, you know, we can't get sugars in as effectively. So lots of bad stuff goes on when we are not using our tissue. And so I'm going to talk about the ACL rehab timeline, but you can apply this to basically any surgical intervention that we have control over. That's not like an emergency surgery where we have a little bit of time. The first window I talk about is pre-surgical. This window is often underutilized most of the time because patients don't know, or the surgeons don't know to send them to us before the surgeries, or don't even think about it. But it's a key opportunity to get people prepared for the surgery, and also to reduce the atrophy that occurs from disuse leading up to that surgery. I also understand that a lot of times patients are not referred into the clinic, and so we don't even see them until post-surgical. About half of my patients, I'm involved in the actual referral to the surgeon, so I've got that contact with them already, so it's a little bit easier for me sometimes. But if you're waiting for the referrals, they can be tough. You might not be able to get that. So that's where we got to educate our surgeons on doing the pre-surgical work to help improve our outcomes for actually post-op. And then with ACLs specifically, I kind of talk about this post-surgical guide of about up to 6 weeks, because by then we should really have most of our range of motion back, and we're just about ready to start loading the tissue, even with high intensity training. So I kind of talk about the first 6 to 8 weeks of really being keys to BFR, that's post-surgical, and then about 4 weeks prior to surgery being key for using BFR to try to get ready for the surgery. And then, of course, it can take up to a year or longer to get to full return to play. And then we can always use it later on for improving our overall performance, or during seasons and other things as well. I tend to look to the Moon guidelines for recommendations on my ACLs. The biggest take home from this slide is that there is really no rigid programs. We have to be very flexible with our programs. That's why I don't really love when people ask me for protocols for certain things, even protocols for BFR, because everybody is different. And so I think that things need to be as individualized as possible. And I really like Greg Meyer's work on his return to play, and having, you know, numerous levels that you try to achieve before you're ready to go to the next level. So that way everybody is individualized. It's not just like you do these exercises for 2 weeks, and then these exercises for 2 weeks, and then these exercises for 2 weeks, and then these exercises for 2 weeks. It really emphasizes these benchmarks in order to hit those benchmarks before you move on to the next phase. So we kind of talk about the standard rehab focus, which is kind of your typical model where we don't really see too much of a mechanical load in patients, because most of the time you can't stress the tissue too much, or they're in a brace, or they're in a cast, or they're in something that doesn't allow you to stress the tissue. But that's when all the atrophy is really coming into play. And so this is the, your typical, like, okay, I might see the patient the week after surgery, and then I can start my rehab process. And like I've mentioned, this really leads to a lot of atrophy. You're going to return to strength training from a much deeper deficit from the muscle size and muscle strength standpoint. We know the high re-injury rates, especially in the ACL. So I believe, and a lot of people believe, that we should be starting 4 weeks prior if we can. You can really do this thing where you start 2 to 4 weeks prior to the surgery to prepare people for the surgery. We can use things like passive BFR. If you're not familiar with that, it's called cellular swelling technique, where you put the cuffs on and you make the limb swell with fluid, and that swelling basically stresses the muscle tissue to stimulate muscle protein synthesis. You can use passive BFR with electric stim to keep the muscles firing. You can use BFR with isometrics. You can use BFR with isometrics and electric stim. And you can do all this stuff even pre-surgically. And then you, of course, can then carry that into 1 or 2 weeks post-op. Some things to note: that if your patients are at a high risk for clotting, then you want to get physician clearance prior to starting any of these things. You're not going to use higher pressures, like you're not going to use 100% limb occlusion pressure in that case. You're going to use lower pressures, 60%. It's still allowing blood flow in. It's just restricting the blood flow out. You're going to do things like only keep the cuff on inflated during the exercise, or what we would call continuous BFR. And then you would deflate the cuff to give the limb a break after about 6 minutes, or the first exercise. And you would do that after each exercise. So you're not allowing that stagnation of blood for too long. To my knowledge, there is no incidence of increased clotting with BFR post-surgically. We all know that post-surgically there is an increase, 100% increased risk with clotting. So it's kind of my opinion that if it was going to clot, it was going to clot with or without BFR. So, you just got to be kind of aware of that, and just, be smart with our programming. But I do think that within this first, like, pre-surgically preparing the limb for the tourniquet, and then this post-surgical 6-week really reduces the amount of atrophy. And so we don't have such a deficit to deal with later on. And some people never get that muscle mass back, even a year after rehab. So like I said, pre-surgical phase starts -4 weeks to 0 weeks, or to surgical date. And I kind of list my stuff here, and these notes will all be available in the portal, where you can go in and download these, and also download the recording as well. And then surgery, and then immediately post-op, weeks like kind of 0 to 2. That's where you're really trying to just get range of motion, get the muscles firing, trying to improve oxygenation, just doing a lot of things to help the healing process. And then after that 2 weeks, you can progress into a 4-week, up to that 6-week. And then from there, you can do a lot of different things. But we know that if we can't stress the tissue at a high intensity because of the injury, we can only really use low loads. And low loads might be body weight or isometrics or things like that. We know that at those low loads, you really don't get muscle strength and hypertrophy changes. You have to take those exercises all the way to failure, or about 1 rep or 2 reps from failure, in order to get strength or hypertrophy. So it might take 50, 60, 70 reps to do that. And that's really where BFR kicks in, is that we can use very light loads, 20% of our 1 rep max, to promote that strength and hypertrophy without the need for that heavy resistance that we can't do in the early phases. It creates a metabolic stress, not as much of a mechanical stress. It creates a hypoxic environment, which appears to stimulate type 2 fiber recruitment through contractions. And that's why also we would use electric stim at the same time. So we're getting some mechanical tension, and we're also getting some contraction. But again, under the cuff pressure. So just a couple studies that kind of demonstrate, I'm not going to go through a ton of these. There's been, gosh, at this point, hundreds of studies that have demonstrated that BFR with low intensity training, or 20% to 35% 1 rep max, indicates moderate improvements in strength. But using low intensity training alone, the effect size is about 0, meaning there is no strength gains. So we've seen, numerous studies. I don't think we have to really try to prove that through research anymore. It's already been done. Really, we don't want to go above anything above 40-45% of 1 rep max. Otherwise, that weight's too heavy. You might as well just do higher intensity loads. So this was one study looking at the UK National Health randomized controlled trial with ACL. And what they showed was better functional improvement, better ranges of motion compared to not BFR, less pain and swelling, and they got comparable strength gains to the high load training. Other systematic reviews. This was looking for studies from 2003 forward, looking at low load BFR in ACL rehabilitation specifically. 4 showed notable pain reduction, 2 showed increased muscle cross-sectional area, 4 showed significant strength improvements. So numerous studies, demonstrating improvements with BFR and low load training. From -4 to week 2, again, here's kind of just the outline so you can follow this later on. Passive BFR is usually where I'll start. That would be a cellular swelling protocol, 5 minutes on, 3 minutes off for 4 rounds. And that's going to be at about, in the lower extremity, about 80% limb occlusion pressure. In the upper extremity, that would be at 50% limb occlusion pressure. Then you can use cellular swelling with electric stim. And you just put the electric stim on the quad. You can use pretty much anything to contract the muscle. So if you can get contraction with a TENS unit, great. If you can get a contraction with a portable TENS unit, whatever you got. I think it would be mean to do because of the wave slope with a Russian stim, but you could do that. And really, you're just trying to get that early quad activation, reduce the atherogenic muscle inhibition, and preserve that muscle mass. And your return of investment on that early action is more muscle preserved, less inhibition, faster strength symmetry, and better return to play readiness. So this is kind of a new thinking over the last 5 or 6 years, really, is getting people prepared for the surgery, using BFR when you can't lift heavy loads until the point where they can lift heavy loads. Then you can transition them into that high intensity training or lifting anywhere 65 to 90% of their 1 rep max. So some key takeaways from tonight: atrophy is fast, deep, and destructive. Typically, traditional rehab starts too late. We must educate our patients and educate our surgeons to make the referral earlier. Early BFR can help preserve type 2 fibers. And I've even used this in people with casts carefully to make sure they don't, create a compartment syndrome, but trying to preserve that muscle mass even when that limb can't be used at all. Again, I used ACL here today, but you can use this really for any of your non-urgent or emergency orthopedic surgeries. I believe early activation gets better functional outcomes, and we must start right away. All right, thank you so much. So next week, or next month, I'm sorry, I'm gonna release an early phase ACL rehab and a post-operative phase ACL reconstruction. So I didn't go through actually, step by step, kind of like a framework here, just because it would take way too long. But we'll have separate courses for that. And next month, for my monthly webinar, I'm going to be focusing on muscle hypertrophy. Like, how do we just focus on improving muscle mass? I am doing a BFR boot camp this December. What the boot camp is really, it's essentially helping people integrate BFR from scratch. Like, if you have no idea what you're doing, things like how to download the app, how to put the cuff on, what's the difference between continuous BFR, resting BFR, and what kind of exercises and program would I be doing around that? And then that'll be kind of like the first 2 weeks. We'll have an active, basically a live session like this, answering questions and a little bit of lecture. Some didactic will be asynchronous, so that'll be just in a portal. And then I'll be available for questions. And then the last 2 weeks are really going to be focused on writing your own programming, because that's the number one question I get is, how can I write my programming for my just my normal fitness, or preventing sarcopenia maybe in older people, or how do I write a program for a patient? So so I want to kind of take it from soup to nuts, how to start, how to download the app, how to do everything in between, and then how to kind of have some thoughtfulness with some programming. Here again is all my information. Mostly I'm on Instagram, and so it's just Ed LaCara, and I'm available either at my clinic email address you can send me to, or I'm just ed@smarttoolsplus.com. All right, any questions that I can answer?
Hello, good evening.
Hello.
Yeah, I'm Dr. Judy from India. Thanks for a wonderful narration and pulling up the most of the detail towards the ACL rehabilitation. So I'm a PhD scholar. We are trying to do pre-operative, pre-rehab using BFR in a complete passive mode.
Awesome.
Especially, we are trying to do with IPC, ischemic preconditioning, just in order to reduce the post-operative inflammatory changes, especially in ankle surgeries, foot and ankle surgeries.
Okay.
mm, we are collaborated with the foot surgeons. So, how do you see, where do you fit actually IPC as a mode of training? It is like most of the time we do with the passive recovery post exercise. So, what's your thought process on IPC as a mode of training or mode of application before surgery, or in order to reduce the inflammatory changes to kickstart the inflammatory recovery?
Yeah, I think that's a great question. I question whether we need to go, because typically, just for everybody else to know, ischemic preconditioning is done at 100% limb occlusion pressure, and it's done 5 minutes on, 4 minutes off for 5 rounds. And it really came from heart transplant and organ transplant, where they would do this ischemic preconditioning to prepare the tissue for these replacements. And what we have found, and what researchers have found, and it's pretty consistent, is that if we use ischemic preconditioning prior to high intensity exercise, you reduce the amount of muscle damage that occurs during that exercise. So I might use ischemic preconditioning prior to a very heavy weightlifting program. I might use ischemic preconditioning prior to a heavy sprint day, or I might be using ischemic preconditioning prior to a heavy plyometric day or a heavy eccentric day, anything to try to prevent this this muscle damage, which would then causes, you know, a longer repair time before I can then use that muscle for the amount of force that I want to use it for, or especially like before games or competition, I don't want it to have reduced muscle force prior to that. So to answer your question, I think that, you know, when we're using it prior to the prior to surgery, you can really go anywhere, like in the lower extremity. If you're using for ankle, I don't think you have to be at 100%. You can do more of like a cellular swelling type protocol at 80% and get the same benefits. I don't have data to back that up, that 80 versus 100, just anecdotally. I don't think that there's a big difference, and it's just a lot more comfortable at 80%. I would think compliance would be a lot better at 80%. And when you're starting to use like e-stim or isometrics, it's going to be a lot more comfortable at 80% than it will at 100%. So I think, yeah, I think that using it pre-surgery is super important to prepare that tissue and really prepare people for the tourniquet, because I think the tourniquet does the most damage during the surgery. I hope that answered it, Doc. Thanks for joining. Adrian, you can access the transcribed notes. It's all in the portal, so you should have access to the portal where you can log in and see the replays. You'll get a replay note, and then we'll put these in that as a PDF as well. Anthony asks, I'm getting a full ankle replacement December 10th. How do I find a local BFR certified PT? I use your BFR tools for the shoulder. I had replaced a few years ago and they have been great. I have the leg cuffs as well. Okay, that's a great question, Anthony. So if you go on smarttoolsplus.com, there is find a provider. And so you can just go on there and find a local provider that can help you. And that's been certified, and you'll see whether they've been certified in level 1, they've been certified in level 2, or they've been certified in both. If you have problems finding anybody local, then I also am available for virtual consults as well. I have a client with fibro who just goes into massive pain after very mild exercise. Yeah, these are tough. Yeah, Miriam, I think that, you know, using passive BFR with them when they're going through these flares is helpful. Even just kind of doing like isometrics with the cuffs, really have to address their autoimmune. I mean, more times than not, it comes down to their food sensitivities, their gut health. I will use peptides like anti-inflammatory type peptides. SS31 is one that I love. Thymosin alpha 1 is one that I love for these autoimmune diseases. GD, I would like to know if we do have any studies that matches Smart Tools auto LOP calculation versus manual calculations using Doppler. Oh yeah, there's it's been validated numerous times. If you send me an email, I can send you some studies on that. Cool. Yeah, GD, just send me an email, ed@smarttoolsplus.com, because I won't remember, and it's 7:40 tonight. Any other questions tonight? Kristen, yeah, you can unmute yourself and come on in.
Hi.
Hi.
Thank you for the presentation tonight.
Sure.
I have 2 cuffs that I use because I had ACL replacement and my meniscus tied down to the suture down on my tibia, the meniscus repair.
Okay.
And my insurance is Kaiser in Northern California, and my physical therapist recommended these, but I don't really have a protocol for it. Like they don't use it. They don't use them at Kaiser technically.
Yeah, they probably don't let them. I'm
Yeah.
from Northern California too. Yeah, it's brutal.
So anyway, I'm at 6 weeks. I've been
Uh-huh.
using them for a couple of weeks now.
Awesome.
And you know, because it's a repair, I still have 2 more weeks non-weight bearing
Yeah.
until I can start. And so I'm just wondering, would I keep using it once I start putting weight down and doing weight bearing exercises? And then also because I'm a cyclist, does it make sense because I do have the go ahead to do no resistance spinning now?
Mm-hmm.
Do you put them on when you're spinning?
Mm-hmm. Yeah, you can do it either steady state, like you can put the cuffs on at 60% limb occlusion pressure and then just kind of go steady state exercise, 20 minutes max without deflating.
Yeah.
And you will use what's called intermittent BFR. So that way at 20 minutes, you can take a rest and then you'll be able to then do it again. So it'll deflate in your rest period. So you'll go 20 minutes of cycling, you'll deflate for 5 minutes, and then you can go another 20 minutes if you want. If you only want to do one 20-minute session, you can just do that. That's fine. You can also do sprint BFR as well, which is you don't use the cuffs during the exercise, you do the cuffs during the rest. So when you're kind of ready for that to get back into cycling, this is more of a performance type protocol, but you'll do like 30-second hard sprint. And then you jump off the bike, you put the cuffs on, you inflate them, and you let the cuffs stay on for 2 minutes. And then you deflate the cuffs, go back on, you do intervals that way. It's been shown to increase VO2 max over the course of 4 to 6 weeks, I believe.
Okay. And is that using the Bluetooth cuffs?
Mm-hmm.
Okay.
Yeah, you could use either. I mean,
And that's what I have, but it tends to take a while to go through all the you have to like press a bunch of different buttons to get to inflating. So that takes
you can always just do manual and go back or use your previous setting.
Oh, I didn't know there was a manual on this.
Yeah, so there should be when you go through the app, you should be able to, it'll either tell you you want to do manual or you want to do personalized. Personalized means it's going to be measuring your limb occlusion pressure again at that session.
Right, it'll calibrate it.
Correct. If you do manual, you can just set it. So what you can do is the next time you use them, write down what your limb occlusion pressure is at by using the personalized. And then that way you have note of it, and then you'll just use 60% of that number for your next session. And then I believe that you can then repeat that session again. So it would be 60%. You'll just go back to an old exercise and you'll be able to repeat it.
Okay.
If it doesn't allow you to do that, it means that you're using the individual, so there's 2 different versions of the app. There's an individual, like I'm just using the cuffs for myself. And then there's I'm using this on other people. And it's a little bit more limited because for safety reasons, we didn't want people to be able to inflate it to 100 limb occlusion pressure, other things that you can't do to try to protect people. So if you can't do those things, it typically means that you registered your app underneath an individual. And what I would do is use a different email address, register underneath a therapist. So that way you have more control over these, because you need more control to do these kind of things.
Got it. Okay.
And then I'll hopefully have this ACL protocol out. I'm hoping to have it out early December. So it would be probably it's going to be like pre-surgical and then 6 weeks, up to 6 weeks post-surgical, and then from 6 weeks on for that. But you could also try to find a local therapist, near you, the same way that I was letting somebody else know how to find a local therapist, or I'm happy to consult with you as well.
Okay. Thank you.
Thanks for jumping on. Any other questions? All right, awesome. Next week or next month, I'm going to say we're going to do BFR for hypertrophy specifically, so building muscle mass. Thanks so much for joining me, and I look forward to seeing you next month. Have a great Thanksgiving. Bye for now.